Well, hello, everyone. For those of you I haven't met yet, my name is Chris Yip, and it's my pleasure and my privilege to serve as the Dean of the Faculty of Applied Science and Engineering. And welcome to another exciting edition of Disruptors and Dilemmas. I'd like to begin by acknowledging the Indigenous peoples of all the lands which we are on today. While we meet together today on a virtual platform, I want to take a moment to acknowledge the importance of the land which we each call home. We do this to affirm our commitment and responsibility in improving relationships between nations and to improve our own understanding of local Indigenous peoples and their cultures. Please join me in a moment of reflection to acknowledge the land on which you are operating. I'm calling in today from Toronto. I'd like to acknowledge that this land on which the University of Toronto operates for thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful for the opportunity to work on this land. Thank you. So I always look forward to these events because it really is a wonderful opportunity for me to connect with colleagues from other disciplines and to learn about their approaches to solving really complex problems and thinking through many key issues. Today's discussion for sure will be an enriching one. We have a wide range of experiences, knowledge, and perspectives are being represented today. And I know many of you are joining us from different schools and faculties from across U of T, including Art and Science, the Rotman School of Management, and Temerity Faculty of Medicine, our event partners. And of course, many of you are signing from across Canada and indeed around the world, which is one of the benefits of this virtual platform. So I'm really excited to learn with you and indeed from you. Today's topic, a very important one, AI advances in healthcare, one which impacts all of us in so many ways, whether it's aging population, increasing rates of chronic disease, workplace shortages. The healthcare landscape is really facing unprecedented challenges. AI, as we all know, it really has the potential to revolutionize healthcare, optimizing workflows, improving diagnostics, creating personalized treatment plans. Here at U of T Engineering, we've taken a really special interest in this topic because it really aligns well with our strategic pillars in engineering of promoting healthy societies by finding new ways to diagnose, treat, and prevent disease, and designing intelligent machines for good by leveraging expertise in analytics and AI. As well, of course, we're based at the University of Toronto, which is really at the forefront of developing promising AI-powered solutions. In recent months, actually, U of T researchers have published new work on using AI to enhance gene therapy, understanding how healthy older adults are aging at home, and of course, incredible collaborations between engineering, arts and science, Temerity Medicine across the university, and the Acceleration Consortium, where, for instance, we're using self-driving labs and AI-gated robotic labs to accelerate the discovery of small molecules for therapeutic purposes. And indeed, just a few weeks ago, it was wonderful to celebrate U of T Entrepreneurship Week at the recently opened Schwartz Recent Innovation Complex, literally just down the street on College, where we are also, in addition to kind of doing the research side, but also ensuring that powerful technologies like AI are safe, fair, and ethical, making the world better for everyone. So it really is an exciting time for technological innovation. And we are really excited to bring researchers together to advance AI technologies and explore new opportunities. It's really critical that we participate in conversations like this, bringing panels together to bring their different perspectives and insights on the healthcare landscape and the emerging role of AI. So first, I'd also like to welcome our moderator, Claire Kennedy. Claire is an alumna of U of T Engineering, ChemEng for the win, a respected and valued member of the U of T community. Time and time again, Claire has really leveraged her knowledge and expertise as a professional engineer and lawyer to help shape and lead key initiatives for the university. She's the former chair of U of T's governing council and past president of the Engineering Alumni Association. She's currently co-chair of the Defy Gravity fundraising campaign, and where she's helping lead a coalition of volunteers really devoted to inspiring the highest level of support for advancing U of T excellence and aspirations. Before I pass the event or pass the virtual mic over to Claire, I want to really thank her for the key role she's played in really creating what is now known as Disruptors and Dilemmas. Many of you may know that it used to be called Biz School, but it really has expanded now into just an amazing, massively open and interdisciplinary initiative. Really want to thank Claire so much for her vision. So on behalf of everyone here, acknowledge your determination and hard work. Thank you, Claire, for that. Also want to thank our sponsors, TD Insurance and Manulife, for making today's event possible. And of course, everyone here today for making space in your calendars for this super important conversation. I know I'm personally really excited to hear the input and the discussion between our panelists. So with that, I'm going to turn it over, hand the virtual mic over to Claire to introduce our panel. Over to you, Claire.
Great. Thanks so much, Chris. I'm so excited to be here today with three great panelists to talk about what is a very popular topic. I think we've had the highest number of registrations for this session as we've had for any disruptors and dilemmas. So you will forgive you'll forgive the cheesy comment when I say that there is a healthy interest in this topic. Let me get right to introducing our three great panelists. Ozzie Balerchi-Drake is a triple alumna of the University of Toronto with degrees from Arts and Science, an MSc in Cardiovascular Research from Temerity Medicine, and an MBA from the Rotman School of Management. Ozzie is the Vice President of Commercial Strategy, Products and Analytics for Teladoc Health and has previous experiences at Princess Margaret Cancer Centre, at the Ontario Ministry of Health and Long-Term Care, and digital startups. She's also a board member at Mackenzie Health, an Ontario-based hospital system, and she chairs its Quality, Safety, and Risk Committee. Welcome, Ozzie. Mohammed Mamdani is the inaugural director of the Temerity Faculty of Medicine Center for Artificial Intelligence, Education, and Research in Medicine, and the vice president of Data Science and Advanced Analytics at Unity Health Toronto. He's also professor at the U of T's Temerity Faculty of Medicine, the Leslie Dan Faculty of Pharmacy, Institute of Health Policy Management Evaluation, and the Dalla Lana Faculty of Public Health. That's another trifecta, triple threat, Mohammed. He was previously named one of Canada's top 40 under 40 and has published 500 research studies in peer-reviewed medical journals. He holds a Doctor of Pharmacy degree from the University of Michigan, an MA in Economics from Wayne State University, and a Master of Public Health from Harvard. Welcome, Mohammed. Milos Popovic is director of the Institute of Biomedical Engineering and the director of the KITE Research Institute, the research arm of Toronto Rehabilitation Institute at the University of Health Network, which is recognized as a world leader in complex rehabilitation science dedicated to improving the lives of people with the effects of disability, illness, and aging. In 2011, he was elected to the College of Fellows of the American Institute of Medical and Biological Engineering, which is a distinct honor. Milos completed his undergraduate degree at the University of Belgrade in electrical engineering, and he holds a PhD in mechanical engineering from U of T. Welcome, Milos. Before we begin, just a quick housekeeping item. The Q&A function you'll see at the bottom of your screen. You can submit questions to the panel. I see a few coming in already. Please use the Q&A and not the chat. We will try to get to as many of them as possible. A number of you did put your questions in the registration, and we've tried to weave those into the discussion. So let me get right to that. The theme of our panel today is AI advances in healthcare. Our healthcare system is facing, I think we would agree, monumental challenges. So what is the opportunity for AI? And help us illustrate that if you could do with a use case. Why don't I start with you, Mohammed?
Sure. I think there's lots of opportunities for AI. I think we have to kind of understand that healthcare is largely data-driven. So from diagnosis to prognosis to treatment, we're always juggling a lot of information in our head. So for example, with many diagnoses, some are actually very straightforward. Others are not so straightforward. We consider things like family history, social history, laboratory values, medical imaging results, vital signs. They say the average complex medical decision considers hundreds of parameters. Some estimate maybe 1,000 parameters for a complex medical decision. And yet, I use this statistic all the time. The famous psychologist from the 1950s, Miller, was able to show us that the average human can process 7 plus or minus 2 things at the same time. So what that means is that we struggle. And even with things like diagnoses, we often get diagnoses wrong because we actually have to consider so many different parameters. There have been studies out there that have shown from simpler things, relatively like a heart attack, myocardial infarction, the rate of misdiagnosis is around 2%, so 1 in 50. Whereas if you look at things like spinal abscess, which is a pretty severe infection of the spine that can have life-threatening implications and result in severe neurological deficits, it's misdiagnosed 60% of the time, right? And common things like asthma, 1 in 3 patients who have been diagnosed as asthma probably doesn't have asthma. schizophrenia. Yeah, probably don't have schizophrenia. So we struggle. And so this is where I think we've been leveraging AI at our institution to develop and deploy all sorts of AI solutions. We've deployed over 50 of them into clinical practice with tangible outcomes. One case example is that we have an algorithm that monitors all of our patients in our internal medicine unit, and it predicts if they're going to die or go to the ICU in the next 48 hours. And it runs every hour on the hour. It's constantly assessing the patients. It considers typically over 100 different types of features, and it's been trained on over 20,000 patients worth of data. And every hour, it's predicting if this patient's going to die or go to the ICU. It categorizes patients as low, medium, and high risk. And as soon as it reaches the high risk threshold, it's automated to page the medical team. Our protocols, the medical team has to come and see the patient within 2 hours of being paged. We deployed this over 3 years ago, and we submitted a paper for publication just a few months ago, where we're seeing a 26% reduction in unplanned mortality. Why? It's because we struggle with identifying high-risk patients, and we need to pay more attention to them. So that's one case example.
Oh, that is a really, a kind of a poignant example. So it's allowing you to really, the healthcare teams to prioritize the most needy patients in kind of separate the forest for the trees. And a 26% reduction in unplanned mortality is enormous. Let's go to you, Ozzy. Talk to us a little bit about some use cases. How is AI changing healthcare from your perspective?
Yeah, so I will come at this at kind of broader, and then I can later on expand on what are some of the things that Teladoc's doing. But when I think about, and when you probably read in the news, cost of healthcare, 1 in 5 Canadians not having access to primary care. In just Ontario, we had 1,200 ER closures in northern rural remote hospitals, and talk about lack of equitable access to care. We talk about physicians spending at least 10 hours a week, probably a lot more, on administrative tasks like writing documentation, helping patients with their navigation, this whole concept of pajama time. And, the challenges that we're facing in hospitals as it relates to nursing and nurse to patient ratio. So these are, significant challenges, and they require, new thinking. And so when I think about domains of healthcare, domains of application of AI in healthcare, let's talk about some of that. So what are some tools that would enhance productivity, right? So productivity of the providers, such as Ambient Scribe, tools that improve operations like AI, workforce management for scheduling, those that replace aspects of a clinician's work, like image recognition, computer vision for dermatology, for radiology, remote monitoring tools. So AI tools that enable removing the barrier for the co-location of a physician or a provider with the patient. And of course, patient engagement tools. So that allows them for personalization, for health screening, patient navigation, digital therapeutics, et cetera. So that's kind of how I think about it. So there are clinical domains, there are operational domains, engagement domains, and that's broadly where I see the application of AI in the healthcare system.
Well, that's a lot. I want to come back to you and have you drill down on one of those, but let me go to Milos first and ask Milos, what do you see as opportunity for AI in the delivery of healthcare?
I mean, it's difficult to add more to what Ozzy and Mohammed has said, but there's a very interesting example that we just looked at it a couple of days ago with one of the students that I'm sharing with Dr. Khan. So we got a lot of these are the patients we have a pressure ulcer. These are diabetic patients which have diabetic foot ulcer. There's lots of them. That's a big problem. And if we don't treat that properly, sometimes they end up having amputation of the foot or part of the foot. So we would like to prevent that. And there are various ways of looking at that. You can look at the wound through imaging and try to determine, based on imaging and other obvious things, to figure out what's happening with the patient. But he did an interesting experiment. He took all the paperwork related to the patients. So do they have moisture, on their feet? Do they have this? Do they have that? Something related to some other seemingly unrelated conditions, which we capture in the documents. And he fed that into AI, found out there were 16 elements of that kind of can help us figure out what's happening with the patient. And through the engine that he has created, he get about 85 to 90% accuracy to determine what is happening with the patient. And when you look at all these individual items, similar to what Mohammed said a minute ago with a much more severe case example, there's the correlations or relationships are like 10% or 9% or 7%. So when you look at this individually, element A, B, C, N, there's no logic in our mind to figure out how this would lead to scenario A or scenario B. But when you package them through this engine, you get very high resolution, very high accuracy based on just paperwork that is in front of you. And we gave up on looking at the paperwork because there's so many elements, difficult to track, and we don't find one-to-one correlation relationship within. So that's an example of the case that I found very exciting and good example for what we are talking today, because we cannot figure out from the data what is going on.
Right. So I think really echoing the point that Mohammed was making about the sort of just managing the volume of data, the intensity of relevant factors, and the ability to sort of sift through that with speed. And identify areas for where human resources can be focused. Really interesting. Ozzy, you talked about a sort of really range of applications: clinical, operational, patient engagement. You must see a lot in your role as VP at Teladoc. Maybe just drill down on, just say one of those, and give us a kind of a more granular idea of how this is really working today.
Sure. So yes, working for a company that has data from 9 million patients, 9 million members, and over 2 billion data points, and 500 million health interactions. It allows us to, having that scale and having kind of that unified data fabric allows us to look at data in that scale. That allows us to really have a unique ways of looking at our data. So when I think about operations, we need to match a patient to a provider every 20 seconds. So 4 million interactions per year. So how do we do that? How do we match the patient with the provider in a way that fits with the provider's specialty, the wait times, the availability, the member's history, the member's preferences, the balance loading and time zones right across? That is a really challenging operational an operational challenge. And so that is like our continuous queuing system is something that's doing that. So it takes attributes that, to going back to Mohammed's point, that a person would not be able to see. So how do we take all of these attributes and match the patient to the right provider at the right time? So that's one example from an operational impact. And I would say another one we talked about is chronic disease, which is how do we now take data from coaching sessions and health questionnaires and connected devices and food logs and activity trackers, et cetera, in a way that engages the patient to continue to take on the behaviors that would help them with their chronic disease. So we've taken that, so using all of that, what I just talked to you about, with connected devices and our kind of digital therapeutic platform as it relates to diabetes, actually engaging the patient with hyper-personalized tools that apply to them and nudge them to the right behavior. And we're seeing reductions in A1C, so one of the markers of health as it relates to diabetes. So that's kind of I would say more of a patient or clinical impact use case that I can talk about.
Right, really interesting. So it kind of having like your own personalized sort of coach, encouraging the kinds of healthy behaviors that will reduce morbidity. Great. Mohammed, we've talked so much about the the many applications. It just sounds so vast. The benefits that AI can bring here. But I wouldn't be a lawyer if I didn't talk a little bit about risk. And we know that ChatGPT, for example, can hallucinate, can get things wrong. Hospitals will have protocols for patients who are hallucinating. What kind of protocols are being developed for an AI kind of health provider that is, I'll call it, hallucinating, getting things wrong?
Yeah, I think the concept of error with AI is really important, and it's a big one. And I think protocols are one thing, but I think education is incredibly important as well. And having an understanding of the limitations of what AI can and can't do. So whether it be diagnosis, prognosis, or treatment, there's algorithms for all of these, and there are going to be inherent error rates. So it will get it wrong, right? But at the same time, humans get it wrong all the time. And so one approach is to understand, well, what is our human error rate and what's the value that AI can add? For certain conditions, like myocardial infarction, for example, we get it right about 98% of the time. So your algorithm is going to have to be that good in order to beat 98% to give us value. Whereas there are other areas, so for example, the ChartWatch example, the thing that predicts if somebody's going to die or go to the ICU, that example that I gave, we actually went to the floors and we spent months doing this. And we asked our doctors, nurses, and our residents, this is not a hypothetical case. You just finished rounding on this patient. You know this patient. Do you think they're going to die or go to the ICU? What's your prediction? And we were able to show, after looking at over 3,000 clinician predictions, that when a physician says this patient's going to die or go to the ICU, they're right less than a third of the time, right? So we know what our error rate is. It's pretty substantial. So now we know what our algorithms rate, what our performance has to be like to add value. So our algorithm beats our clinicians, which is great because that's how it's going to add value, but it still gets it wrong. So the approach that we've taken is not simply a process or a policy to say, just be careful. It's an incredible amount of education and culture change to say, the way this is going to work is when humans collaborate with AI, right? So what we tell our clinicians, and this is the ethos that we live in at our hospital, is when the algorithm says the patient's going to be in trouble, and you as a doctor say, no, they're not, believe the algorithm. Don't believe yourself. But when you feel the patient is going to be in trouble and the algorithm says, no, they're not, don't believe the algorithm. Believe yourself. And it's that joint collaboration between the two that I think has resulted in our 26% reduction in unplanned mortality. It's them working together because there's errors at both ends.
Right,
So
that's interesting. So it's not kind of a, I'll call it a blind adoption of the technology. There's always this sort of human judgment. And the example that you're providing is that you sort of err on the side of risk to the patient. That's a really interesting sort of elaboration. I think you make an excellent point about the bar that AI has to beat, and it'll be different with different conditions and different situations. Well, let's move from error though to bias and to ethics. Milos, you're the director of the Biomedical Engineering Institute. You're in the business of educating future healthcare professionals who are going to be adopting AI. Talk to us about how you're incorporating, how U of T is incorporating ethics into education. What is this interface between the technology, but the ethical considerations as well?
I mean, presently, to be absolutely frank, I don't think we are really at a point in time where we're fully comprehending where AI is going to come from the ethics point of view. There are challenges, there are obvious challenges, and so we have very well developed what ethics procedures and processes for running clinical trials, for doing experiments with animals and humans and whatnot. And we train our students to understand that and, follow the processes. Now, with AI, we have a little bit of a tricky situation, right? Because pending, and Mohammed knows it better than I do, depending what kind of information you're feeding the system depends what kind of biases the system will have. So if I get most of the data based on Serbian population, right, for example, you will have a bias because you don't have Asian population and you don't have other representations, right? And so we have experience with other systems in the past and facial recognition, other things that if the system is not trained properly, it doesn't have proper samples, then it starts behaving funny and gives some results which can be quite disturbing, actually. And so the thing is, one has to train students who are going to use and are using these tools to try to represent the cases and case scenarios that are representative of the population and the real environment they're dealing with. And problem with us is our environment may be very different from the environment in Tokyo. And then the tools and applications that we have created, and they're valuable and very effective in Toronto environment, may not be as effective in Tokyo or in Japan. And we are not always grasping that. And I think coaching students to understand that and look from this all different and look for potential pitfalls of their choices of data and what do they train is very important.
Very important, yeah. So that quality, that sort of quality concern is overriding. We've had a number of questions from registrants, from our audience members about bias and dealing with bias. So let me take that question back to you, Mohammed. How are you and your colleagues confronting this issue when it comes to AI applications?
Yeah, it is challenging practically. So the theory would say that you look at bias comprehensively and across the board and all that sort of stuff. And I completely agree with the theory that we should do our due diligence. That being said, there's a practicality to all of this. So what do I mean by this? When we look at our algorithm performance, we need to understand how well it performs in certain segments. So for example, does it perform just as well among young versus old? We subject many of our algorithms through these sorts of assessments, and we're able to find, yes, sure it does, because we have their age. What about sex, males versus females? Yep, performs just as well among males versus females. Great, we have sex data. What about sickness? Very sick people versus not so sick. Yep, we can do that. We have comorbidity data. What about race? We don't have race data. So can we tell you that it performs just as well for one race versus another? We can't. That's just the reality of our data here. Now in the US, they're much more aggressive about collecting race data. In Canada, we are not. So in most hospitals, we don't collect race data. What about gender? There's over 100 genders. So are we going to look at every gender? We don't have gender data. So you're in a dilemma now to say, we have the data that we have. We're going to do the best we can. And we can look at, for example, 40 parameters of bias. And I can guarantee you, if I go to a conference, somebody's in the conference is going to raise their hand and say, what about 41, 42, and 43? We can do 100. And somebody's going to say, what about 100, 100, 203? Where do we stop? Where do we say it's good enough? I don't think we have definitive answers for that. So inevitably, there's going to have to be a judgment call. And some may argue, is it ethical for us to deploy these algorithms where we don't have race assessments? And I would argue we can stop. We can actually pause and say, we're going to wait for race data. Maybe we'll wait a decade for it to come. We can remove our algorithms and let 26% more people die every year. So what's more ethical?
Right. Yeah. Some really thorny questions there. I want to shift the discussion a little bit. A lot of the applications that we've talked about, the one that you've highlighted, Mohammed, maybe it's in the ICU about those anticipated to die or go to the ICU within 2 hours. Milos, you were talking about a wound care regime. These seem to be the kinds of applications that would be deployed in institutional, kind of settings. But I've got my Fitbit on my wrist. I can't say that I'm going to feed it all the steps that it needs today. And this kind of wearable technology has gone, well beyond counting steps to, heart rate monitoring. I think there's versions for blood pressure, et cetera. Is there something really here, sort of meaningful from a healthcare delivery perspective, in terms of wearables, or is this, a bit of kind of, I'll call it health jewelry, or kind of a faddish? Let me go to Milos on that, and then Ozzy, I'd love to bring you back into the conversation, and maybe you've seen some, applications that do involve wearables. But let me go to you, Milos, on this one.
So let me put the philosophical angle on the healthcare business, right? We like to maintain our cars, right? We go change oil, do things, manage them. We don't do that with patients. Usually we wait until something happens, catastrophic or semi-catastrophic, and that's when they knock on the door, go see the doctor and manage that. Now, the benefit of having wearable technologies, whether they're in form of textiles or whether in form of jewelry, as you suggested, has an opportunity to actually monitor people when they're healthy and they're doing really well, to monitor how their various physiological functions are evolving with time and their age, and potentially can predict that something is going in the wrong direction way ahead of the time the problem actually occurs. And then what we can do is we can intervene ahead of the time before the person gets an event. So here's a simple example. So we can right now create a t-shirt which can measure the sounds while a person is sleeping. We can determine if somebody has sleep apnea. And if we know the person has sleep apnea, we can treat them. And by treating them, we reduce opportunity of those people getting stroke 4 times. So instead of 4 people because if you have a sleep apnea, the chance of getting stroke or having cardiac event is 4 times greater than in normal population. So just removing that away reduces the number of people who are coming to the emergency room, on that particular topic by 4. So I believe that the future of healthcare is not in the hospitals, and now my CEO is going to come and shoot me. But I believe that the future is in managing patients at home through wearable technologies, through surveillance, as long as it's done properly and ethically, and manage patients and treat them way before the problem arises, and enable people to age at home independently and maximize their life outcomes based on prevention rather than treatment. And I think future of the healthcare should be in prevention. And that's where AI and wearable technologies will play a crucial role.
Interesting. So there really is something kind of there in terms of these wearable technology. And you've raised a really interesting point about privacy, and I want to come back to that. And I'm going to go to Mohammed on the privacy question, I think, because I think we've had a number of questions from the audience on that. With the concerns around cybersecurity, you can imagine that there would be a trove of data that somebody would want to get their threat actors would want to get their hands on. So I'd love to hear about how institutions are addressing that, and I'll come back to that question. But Ozzy, I wanted to bring you into the conversation on what are the prospects for wearables? Do you agree with Milos that there's really a there and a material kind of case to be made for wearables in the delivery of healthcare, maybe on the preventative side?
Yeah, so I think about wearables as things that produce data, and whether that data is useful or not, it depends on what you're going to do with it, right? And so there are these wearables and sleep tracking, and what I call the San Francisco biohacker bros, and some of the tools that they are using, and maybe down the line more of the broader population will start to adopt it, and they're just tracking their health. or as it relates to just a person's actually going through a disease or potentially being at risk of disease, right? So there's the wellness, as Milos talked about, and there's the disease. And so, as it relates to some of these trackers, we absolutely use them. They are already being used to manage chronic diseases, right? And so through your CGM, your continuous glucose monitor, we see that there is an elevated blood sugar, and we send you a nudge to, let's say, go for a walk. We see from the wearable that you have not gone for a walk. How do we escalate that? Do we have a coach that calls you, right? So this is actually already in practice and in use. I also think about wearables, or actually, Milos, you talked about it from a non-wearables or surveillance, right? So in my past job in senior living, how do we enable patients or the elderly to stay at home? And so there are monitoring solutions through, again, radar and sound and image recognition just at their home to track whether their health is deteriorating. So for example, it's something that can track and say, this person used to wake up only once during nighttime to go to the bathroom, and that has increased, for example. So the AI shows deviations from a patient's current practice or current behaviors, and it can predict UTI, it can predict early signs of dementia, and there are many different things that the AI can predict. And therefore, to your point, to the point of, is someone going to do something about it, right? So is it just for the sake of giving some peace to the loved ones of the parents who are living at home? Is there someone, a clinician, monitoring and can actually deploy resources to the patient? So those are some of the things that we think about in terms of wearables or non-wearable kind of surveillance devices and patient monitoring.
Yeah, lots of applications there, and I think that the the ability to keep seniors in their homes longer will have a potentially a big impact on the quality of their life. Most people want to sort of age in place and not to be aging in an institutional setting. As well as implications for the cost of the system. But the points that you're raising about even the surveillance in the home, which is directed at a good end, kind of brings us squarely back to this issue of privacy and when is it too much, or what safeguards do we need to have in place? So Mohammed, let me go to you with that one.
I think so, in terms of privacy, it's a bit tricky. And it's a cultural issue, I think, really, right? Because how many of us actually download apps on our phones and just click agree without even reading what it's asking us for? And it tracks not only within apps, but across apps on our phone and all sorts of sensitive information. We do it all the time, right? Yet some people get really anxious about, well, you can't have my health data. Well, first of all, who has it? And for what purpose are you using it for? In our organization, everything that's done is behind our own firewalls, within our own environment, on premise. So we don't put data on the cloud yet. We will be. I think everybody's going to be moving towards that. But really having assurance is number one around that your data is safe and that it's private. Number two is around education and knowledge, that the patients know that their data are being used for certain purposes. You're much more well-versed at this than I am, but my understanding is that for quality improvement purposes, explicit consent is not needed. It is a function that hospitals perform. And so if AI is to be construed as an quality improvement activity, then there is some liberty around how the data can be used for AI. Whereas if it's a research project, it's a whole other kettle of fish, where you do need informed consent and go through a whole other process. So we're still, I think healthcare in general, the world in general, is still trying to figure out what kind of paths we're going to be taking. At the end of the day, it's going to be around making sure your data are safe and private, and making sure your environment is that way. Number two, there's a lot of education. And number three, there's patient engagement or public engagement. And so again, when I'm going back to that same example of this thing that predicts if somebody is going to die or go to the ICU, patients were actually involved in that process to say, here's what we're going to be using the data for. Are you okay with it? When do you want to know that we're actually alert? This thing is telling you it's going to be you're at high risk. Do you want to know? How do you want to know? So that engagement helps quite a bit, and it eases tensions between that discussion around why are you using my data for what purpose and how.
Right. So, some education there, and then the point that you're making about maybe different thresholds for different uses is an important one. But I was really struck when Milos was talking about I'm going to have a low tech T-shirt for when I indulge in my guilty pleasure of salt and vinegar potato chips, and I will wear a different T-shirt when I'm eating my greens. Okay, we've had a number of questions about what are the barriers to the implementation of AI, whether they're kind of technological failures, because in any rapidly advancing technology there are setbacks. We're also in a frankly a resource constrained system. So what are some of the challenges that you see? And I think I'm going to go to all our panelists on this one because it's a big question. Let me go back to Ozzy, and then I'll go to Milos, and then I'll come to Mohammed on that.
So I think some of the challenges as it relates to the adoption of AI are actually good ones, right? We talked about privacy. We talked about some things around accuracy, right, of the model. So whereas a 95% or 90% accuracy in my email text prediction, while it's annoying, it's not going to be life-threatening, depending on who you ask and how frustrated you are at that moment. But something that relates to your health, or the health of yourself or your moms or your children, people expect a much higher accuracy. So those are good reasons. And there's some not so good reasons for the adoption of AI to slow down. I would say the interoperability of our health records, right? So we don't have a complete, we have incomplete health records, even for a person, and we don't have interoperable health records. So, my primary care physician may not know what happened to me at the hospital, or, what drug I'm getting from this pharmacy versus that online thing, et cetera, et cetera. And so that's one challenge. The other is the lack of incentives for the adoption of AI. So that could be policy, funding, incentives, and we see that whether any technology solution, the incentives that exist really make the business case for the entrepreneurs, for the startups who are or for the researchers who are developing those AI tools to actually adopt it. And then I would say with everything in healthcare and perhaps many other industries, it's around change management. So the change management to me that's required to reap the benefits of AI becomes a barrier. So if you include or introduce a new AI tool, but you don't change the system around it to reap the benefits, then you've just added costs and you've just added a tool, and you haven't really reaped the benefits. And with our kind of overburdened workforce, they can be hesitant to actually go through the change management that's required to change the operating model. I would be curious, Mohammed, like what are you seeing, beyond the adoption of these tools at St. Mike's, and I know a number of other hospitals. I would say that's probably the single most impediment to adopting, because it's a project, right? It's something new that we have to put resources to before we can see any benefit out of it.
Yeah, it needs an upfront investment, and I think you're absolutely right. You need to create incentives in the system. So we're going to have to get a healthcare economist. Well, and you've got a degree in economics, Mohammed. But there's a whole policy sphere here as well that I think we could have another whole panel on here, and perhaps we'll do this again, invite some of our colleagues from Munk. But let me come to you, Milos, on this question of, what are the resource constraints or key resource constraints? How do we go about integrating this? Is it, is the real issue the, kind of frailty in the technology? Is it a resource constraint? What are the kind of key barriers that you're seeing?
It's multidimensional, so I cannot go through all of them, but I'll give you one very simple example. I was in China about 4 or 5 years ago before we had COVID, right? And their healthcare data system is fully integrated, and you can find all the data points from any hospital in China in a matter of seconds. We don't have that in Toronto. We're struggling. Every hospital has its own data, servers, management, protection, documentation. Yeah. So AI really thrives when you have huge amount of data on the same type of patient population. For example, in Canada, we have spinal cord injury population is very nice example because there's about 1,000 people who have new injuries, or I'd say 4,000 people have spinal cord injuries every year. These are the most expensive patients that we have because that's catastrophic event. People become paralyzed. They're not able to use their arms, legs, and whatnot. And we have in Toronto, we have phenomenal center, which is called Lyndhurst, which is managing these patients. They have 250 patients annually. And another center is in Vancouver. The third center is in Montreal. These data are not shared. They're not combined. And out of 200 patients, you can learn very little. However, the savings that you can have by figuring out how to prevent pressure ulcers in those patients, and almost every single spinal cord injury patient has a pressure ulcer, it's $100,000 price tag per injury. And we are not we have no means to share the data and experiences and knowledge. So if we want to deploy AI in that particular space, we can't because we have no means to do it. So we need to create an and Mohammed would know this better than me, we need to create an infrastructure to allow data in the whole country to be gathered in a safe and effective way, and maybe share it with Germany and US so we can get all these different populations together to extract, to learn from the data and empower AI to get way more predictive, better in making decisions and yada, yada. So I think that's, in my opinion, that's one of the big problems, but
yeah,
that's one
I
angle.
think you're highlighting the point that Ozzy made about incentives in the system. I will just say that my kid's family doctor still uses a fax machine, believe it or not. So I can't believe I'm having a discussion about really cutting edge AI, and we've still got fax machines that are at use in in Toronto in the healthcare system. Mohammed, let me come to you on this question about barriers.
That's a great point. I think Ozzy and Milos have went through some incredibly good challenges, fairly broad, but I want to pick on your point, Claire, around a sector that still uses fax machines, right? It is about culture. It's about oftentimes what people are willing to do. It may not be the right thing to do, but it's what people are willing to do. So having an understanding of it, healthcare is driven by our healthcare professionals, our healthcare providers. It's driven by systems administrators, decision makers, policymakers. It's driven by a multitude of folks. What are their biggest pain points where they will want to change if you address them? And so the model that we use at our hospital is all of our initiatives are never driven by researchers or by data scientists. They're always, always, always driven by end users. These are the people who struggle with the questions and the problems every single day, who are desperate for solutions. So if you give them a solution to their fax machine and they say it's not going to interrupt my workflow and it's going to make my life so much easier, I'm all in. I want to work with you in developing a solution that will work for me in the system. That, I think, is going to get across the cultural barrier that we see around, I don't have time for this. I'm not engaged. I don't want to do this. So no matter how good the solution is.
Yeah, you want to look for volunteers. You want pull, not push. And there's enough opportunities, it sounds like, for pull. We're coming up to the top of the hour here. We've got so many questions. So I'm going to try and pick up the pace, and I'll just go to kind of individuals and try and hit some questions. We got so many that have come in from the audience. Thank you to our audience for some really thoughtful questions. We've talked a lot about, sort of interdisciplinary, but I think the model still is, sort of doctors and nurses and trained health professionals. What are the opportunities for people in sort of other professionals, data scientists, data analysts? How are they going to get integrated? I'm going to go to you, Milos, because you're kind of at the front line of educating our next generation. What are the opportunities here for, let's say, those professionals who are not MDs in this what sounds like a burgeoning field?
I mean, medicine is becoming technologically very heavy, that we don't appreciate that or acknowledge sometimes. That's a different problem. But so AI is one of the tools that will come in, and we will see more engineers and computer scientists entering healthcare ecosystem because they're needed. They're needed to collect data, they're needed to process the data, they need to store the data, they need to manage the data, and needed to maintain the systems. So, and we're in biomedical engineering program, so we are training and coaching our students on basics of AI, deployment, how you can use it in the healthcare system. Then we send them to clinical settings where they can try and train and develop some of the tools in real life situations. So I see a large number of engineers and computer scientists entering the workforce in hospitals in the future, in the near future. And I think we will be pressed as a school of engineering to train and provide that kind of skill set.
Well, I will say that U of T is always on the forefront of training and education. So I know that U of T is up to the challenge. We've had a question here on mental health. Maybe I'll go to you with Ozzy on this one. Have you seen, or do you anticipate applications in AI that are directed at mental health? We've talked a lot about physical health manifestations. Are there applications here in mental health that you see or that you're anticipating?
Yes, for sure. It is kind of similar to the concept that I talked about around nudges, right, to improve health, and that could be applied to both physical and mental health. So, of course, there are a number of kind of cognitive behavior, online or digital cognitive behavioral therapy, dialectic therapy, et cetera, tools that are available that are engaging the patient to continue to input and track their mood, track their, anxiety, depression, or overall well-being, and send them nudges or next best actions to address, let's say, any issues with those scores, if you will. But we know that, again, as is with physical health, it's the combination of human and technology. And so, while certain aspects of a person's job or as therapist or psychiatrist's job may be replaced by AI, that human touch will not go away. And so the way kind of I think about it, the best predictor of success in mental health therapy is the relationship between the therapist and the patient, right? This thing they call it like therapeutic alliance, right? And so how long will the patient stay with that therapist to address their issues? And so that's where I also see an application of AI, right? So whereas the patient may, choose a specific provider based on whatever, I may choose based on my ethnicity or based on the fact that, I don't know, they're from Toronto or whatever the case may be that I may choose, AI can actually look at all data, all attributes, all instances of matching, and propose a provider, a therapist to the patient that actually is predicted to have the longest, call it a patient-provider relationship value. And so certainly that's something that I can see the application as it relates to
maybe
AI
we'll have
health.
a matchmaking application called Minder as well.
Yes.
That will be matching the therapists with patients. So we're almost out of time. I want to go to a speed round. I'm going to ask our panelists to be super brief here. I'm going to ask you to make a prediction. You're not going to be held to it. But what seems outlandish today in healthcare that will become routine in, I'm going to say, 15 years as a consequence of AI? I'm going to go to you, Mohammed, and then I'm going to go to Ozzy, and then I'm going to go to Milos. So keep it short and surprise us.
I'm going to say the virtual doc, AI that actually is a very strong companion to the physician that'll actually help screen patients.
Cool. Ozzy.
Okay, Mohammed, you stole mine, so I'll try and come up with another one. Maybe an AI that predicts if you're going to have a heart attack and sends you an ambulance to your home.
Oh, okay. Milos, bring it home.
That's difficult. I mean, I think we can get to the point that you have an AI who kind of like an annoying mother sitting on top of you and tells you what to eat, what to do, what exercise you should do, and you don't actually have to go and see a doctor in the long run. That's my prediction.
All right. Well, I don't know that my kids are going to be looking forward to someone who can nap them more than I can, more consistently than I can. But thank you. What a great, fascinating discussion. I've learned so much today. On behalf of U of T and our audience, I want to thank our panelists, Ozzy, Mohammed, and Milos, for a really, really rich discussion. I want to thank also our sponsors, TD Insurance and Manulife, for their consistent support of Disruptors and Dilemmas through the U of T Affinity Partner Program. And I want to thank you, our audience, for your engagement. We've had fantastic questions, and your interest and enthusiasm for Disruptors and Dilemmas keeps us innovating on topics and brings us back. So whether you're near or far, thank you. We look forward to having you join us again. Until the next time, all of us at U of T wish you good health and good spirits. Thanks so much.